In this segment, we're going to discuss the spinal cord. The spinal cord is about 18 inches long, so that means that it does not occupy the full length of the vertebral column, at least not in adults. From ages to about 4 years of age, the spinal cord and the vertebral column are about the same length, but then the vertebral column will start to grow beyond the spinal cord, and the spinal cord will more or less stay its same length at this point, so that by the adult age, the spinal cord ends between the vertebrae L1 and L2, somewhere around in there. So in other words, it ends at the extent of the upper lumbar vertebrae. We will see that it has a bilateral symmetry. So if we look at the model here, we will see that we have gray matter arranged on either side of the midline and white matter in this symmetrical arrangement. We will see that we have a large groove called the anterior median fissure, and that's going to denote the anterior part of the spinal cord. The posterior median sulcus is not as large, but this is the midline of the spinal cord. We've got our anterior median fissure, our posterior median sulcus. We've got our gray matter arranged in this H shape around it, and then we have white matter tracts surrounding the gray matter. You'll also notice that we have these roots coming out of the side. We have a ventral root, sometimes called the anterior root, but in this class we'll prefer ventral root, and that is going to provide a pathway for axons that are going to be arising from this anterior part of the spinal cord. Those axons, the cell bodies for those axons, will be in this anterior part of this gray matter, and this will be providing motor signals. So motor commands will be exiting this anterior part of the spinal cord, and this little ventral root will join a spinal nerve. We have a posterior root, which is going to be bringing information into the spinal cord, and this is going to be sensory information. So we have here a dorsal root ganglion, and this is an area where we're going to have neuron cell bodies. So we have two enlargements of the spinal cord, one of which is called the cervical enlargement. It's around the neck region, so it's right at the border between the cervical and thoracic regions, and this is where we're going to have a large amount of gray matter. And this is because we're going to be supplying areas of the body that have very fine motor capabilities as well as very fine sense of touch. So we're going to be supplying the upper limbs and the upper torso. And as you know, your hands have quite a bit of dexterity, and you also have a very fine sense of touch here. So we're going to need more neurons to process this information. So that's going to be at the cervical enlargement. Likewise, we're going to have a lumbar enlargement, and that's going to be involved with both motor and sensory information for the pelvis and the lower limbs. So this lumbar enlargement, we're going to have more gray matter in there, so we have more neuron cell bodies to process this information. All right, the end of the spinal cord is called the conus medullaris because it has a cone shape. So think of canonical or conical, is like cone, conus medullaris. So this basically is the spinal cord below the lumbar enlargement, and it tapers at the end. And the end, since the spinal cord does not occupy the full extent of the vertebral column, we have kind of a guy wire. And this is called the filum terminale. And this is basically the thread of fibrous tissue at the very end of the conus medullaris that's going to hold the spinal cord down. And it attaches to what is called the coccygeal ligament. And the coccygeal ligament is basically what attaches to that coccyx, and it's going to keep the spinal cord really from moving. And it's going to anchor it down very much like a guy wire anchors down a radio tower. We also have what's called the cauda equina. And the cauda equina arises from the fact that we have 31 spinal nerves, and they all have these roots that are associated with them. So we're going to have a ventral root and a dorsal root that's going to be bringing information away from the cord or to the cord. Ventral is going to be away from, dorsal is to the cord, but we're going to have this spinal nerve here, and we're going to have 31 of these. But because our spinal cord is not as long as our vertebral column, we're going to have some of these spinal nerves sort of flay off and splay out. And it's going to create a shape that looks very much like a horse's tail. And cauda, as you recall from previous lectures, means tail, and equina means to do with horses. So equine is horse, so cauda equina is the horse's tail. And if we look at it, and if you've actually held a human spinal cord, you will see that the nerve roots coming off of it actually do sort of hang down and look like a horse's tail. Now, one of the first things you'll notice looking at the cord is the way it changes shape as we go through the length of it. So we'll notice up here that if we take a transverse section from one of our cervical segments, it will have this type of shape, whereas if we move down into one of the thoracic segments, we'll see that the gray matter is quite a bit smaller. And one of the reasons for this is the only thing that we're supplying here will be our thoracic nerves. And the thoracic nerves don't control any major limb movement or anything like that. So they don't have anywhere near the need of motor neuron cell bodies that we would find up here. And the amount of sensation that we're going to receive is also not going to be as great as, say, something from our fingertips. So the amount of gray matter in the cord is not going to be as much there. And then we can move on down to our lower segments of the cord, and we can see again how the gray matter is going to change here. And notice when we get into the conus medullaris that the white matter, that is this part here, is going to be quite small because we're already at that cone shape where the cord is tapering. The other thing that you will notice is because the cord is not as long as the vertebral column, this is why we have our cauda equina. The nerve roots of these spinal nerves are going to have to come out at the intervertebral foramina of the vertebra with which they're associated. So what do I mean by that? So the spinal cord has 31 segments. And each of these segments will be named with a corresponding vertebra. Now we have 24 vertebrae, as you recall. We have 7 cervical vertebrae, we have 12 thoracic vertebrae, 5 lumbar vertebrae, and then we have the sacrum that, if you remember from lab, is going to be 5 fused vertebrae that have all fused in one bone. We have 5 of those, and we have 1 coccygeal vertebra, which, well, is part of the vertebral column. Is really anywhere from 3 to 5 fused bones, but we'll count it as 1 vertebra for our purposes. And what we see when we add them up is we get 30. And we have 31 spinal nerves. So we will notice that we have 1 more cervical spinal nerve, or spinal segment, I should say, than we actually have cervical vertebrae. So we'll notice that each one of these things is named for an associated vertebra. So C1 is going to be associated with the atlas, C2 will be associated with the axis, and so forth. So our sacral segment 1 will be associated with this first sacral region, our first sacral vertebra. And notice our sacral foramina now are going to be where these particular segments or these particular nerve roots associated with that segment of the spinal cord will exit. So the first conundrum we have is the fact that we have 1 more cervical segment of the spinal cord than we do have cervical vertebrae. So we'll notice that the nerve roots of spinal segment C1 through C7 come out above their corresponding vertebrae. So C1 segment nerve roots come out above the atlas. C2 segment nerve roots come out above the axis. C7 nerve roots come out above the C7 vertebra. The C8 segment nerve roots will come out below the C7 vertebra. And from then on down, the segments, the nerve roots corresponding to that segment will come out below the corresponding vertebra. So T1 nerve roots will come out below the T1 vertebra. The T10 nerve roots will come out below the T10 vertebra, and so forth. And now we run into that other issue of the fact that the spinal cord is not as long as the vertebral column. So when we get down to these lower segments, remember our conus medullaris ends at around L1 or L2. And this is where our sacral segments of the cord are going to be. So these nerve roots are going to have to travel a long way down to get to their exit points. And this is why we have the cauda equina. Now, as we've noticed, the spinal nerves have basically two roots. We have a dorsal root and a ventral root. So going back to the model again, we remind ourselves we have the dorsal root with its very obvious dorsal root ganglion here, this bulge. This whole segment is the dorsal root. That's the dorsal root ganglion. And we have the ventral root. And we will remember that the ventral root is carrying information arising from cell bodies in the anterior part of the horn. And in some cases, we'll see there's a lateral gray horn. We talked about that in lab, and we'll talk about this in later lectures. But this whole front part of the spinal cord is going to have neurons for basically cell bodies of motor neurons. And those axons are going to exit via this ventral root. So we can think of ventral root associated with motor function. The dorsal root will be bringing sensory information into the posterior part of the cord, so we can think of the dorsal root associated with sensation. And as you probably remember, we talked about the fact that a lot of sensory neurons, peripheral neurons coming in, are what we call pseudo-unipolar. So we recalled that from a previous lecture. So they have their cell bodies hanging off to the side. So we have this long axon, and we've got the cell body hanging off to the side. And the dorsal root ganglion is where these cell bodies are going to reside. So this is an important area because this is where the cell bodies of those pseudo-unipolar neurons will be. And so we know that we have both a ventral part and a dorsal part. The ventral part supplying the motor commands from the anterior part of the cord, the dorsal root bringing sensory information from the periphery to the posterior part of the cord. And these two roots come together to form the spinal nerve. So spinal nerves are mixed. What does that mean? That means they're going to carry both afferent information, that is information coming to the spinal cord, and this is going to be sensory, and efferent motor fibers. So remember, our efferent exit the spinal cord, it's going to innervate an effector. So these efferent nerves, their axons are going to leave via that ventral root. All right, so now let's look at it a little bit from the outside. So we've looked sort of at the segments. We've got our gray matter, we've got our white matter, we've got columns of white matter surrounding the gray matter. This is where axons running up and down the cord will go, and they will be bringing information from the periphery, up to the brain and so forth, and vice versa. So we'll see the organization of the white matter tracts later on. We can see that each one of these roots has these rootlets all arising from the same segment, and they're going to join to form the root. So here we have our dorsal root. We're looking at this posteriorly. So we have our dorsal root. We have these little rootlets that are coming in all to the posterior cord of the same segment. Here's our posterior median sulcus here. You can see the anterior part of the gray matter up here is going to have our neuron cell bodies, and notice that we're going to have these little rootlets here. These little branches are called rootlets, and these are going to come together to form that ventral root. Now, we can also remember that the spinal cord is covered with meninges. So the meninges are continuous with those of the brain. So we've got the pia mater, just like we have with the brain. And that's going to be right flush against the tissues of the spinal cord. Then we're going to have the arachnoid mater, which has that subarachnoid space through which the cerebrospinal fluid will flow. And then we have the dura mater, that tough outer covering. Now, the dura mater has, between it and the actual bone of the vertebral column, we're going to have a space called the epidural space. And it's going to be filled with adipose and other tissues, connective tissues. It's going to pad the spinal cord. Now, we don't have this epidural space in the brain. In fact, as we go rostrally, or I should say cranially, the meninges, the dura mater, will eventually, when it gets to the foramen magnum, it will then fuse with the periosteum. So it will then become fused to the inner surface of the skull, whereas the meninges within the spinal vertebral column, I should say, are going to have a space between them and the surrounding bone, and that's called the epidural space. And just to orient you, this is the posterior part of the spinal or vertebral column as well. So we have our spinous process, we have our transverse processes here, and in front of the spinal cord, we're going to have our vertebral body. All right, so as we've said, the spinal meninges are going to protect the spinal cord. They're going to do two things. One of the things, we're going to have our blood supply. We're going to have blood vessels flowing through the spinal meninges, and we're going to have that shock absorption, that same shock absorption that we saw in the brain. Anytime we get an infection of the meninges, it's called meningitis. We have an inflammation there. You can have spinal meningitis, meningitis. Gosh, I can't talk today. You can have spinal meningitis or cerebral meningitis. It just depends on what part of the meninges get infected. All right, so we've already talked about the 3 layers of the meninges, and we know that cranially this is going to fuse with the periosteum of the occipital bone. That's going to be continuous with the cranial dura mater. Caudally, it's going to taper to form this cord of collagen fibers. That's going to become part of the filum terminale, that cord that anchors the spinal cord to the coccygeal ligament. The epidural space is that space between the dura mater and the walls of the vertebral column. As we said, this is going to contain our loose connective tissue and adipose tissue. This is the common site of something we've probably heard of called an epidural injection. And this is where anesthesia is put when someone's about to undergo surgery. A lot of times, women about to undergo childbirth will get an epidural injection. Sometimes men about to undergo a prostatectomy or a prostate operation will undergo an epidural. Basically, they're injecting anesthesia to put to sleep the sensory part and even the motor part of that level of the spinal cord. All right, so the arachnoid matter is that middle meningeal layer, and that's going to have an arachnoid membrane, which is a simple squamous epithelium that is going to cover the arachnoid mater. And you remember the arachnoid mater has those trabeculi and the space between the trabeculi through which the cerebrospinal fluid will flow. The subdural space, here again, we should not have a subdural space in a healthy individual. So this is only a potential space. So hopefully the space will not open up. And as we said, the subarachnoid space, this is going to be between the arachnoid and the pia mater. Remember, we have our arachnoid trabeculi in here. That's basically collagen and elastic fibers that look like a spider web, hence the name. And that's going to be filled, those spaces between those trabeculi are going to be filled with our cerebral spinal fluid. Sometimes people will do a spinal tap or a lumbar puncture, it's the same thing, to withdraw some of the cerebrospinal fluid. And this can be done, for example, to look for biomarkers of pathology, for one reason. Another reason one would do a spinal tap is if someone makes too much cerebrospinal fluid and is not draining it out quickly enough. And so they can actually have too much pressure building within the meninges. And so occasionally some of that pressure is going to need to be alleviated. And to do that, a spinal tap is often performed. For most people, getting a spinal tap done will cause a tremendous headache. For people who have an excess of cerebrospinal fluid to begin with, they're going to get tremendous headaches, and the spinal tap will relieve some of that pressure. All right, the pia mater, as we said, is that innermost meningeal layer, just like the brain, and it's basically collagen and elastic fibers, and it's going to be bound directly to the underlying neural tissue. All right, we have some special structures within the spinal cord that we don't see within the brain. For example, we're going to see sort of extensions of the pia mater to the dura, and this is going to be called the denticulate ligaments. Denticulate because they look a little bit like teeth, and that's going to prevent a lot of lateral movement. And then we're going to have blood vessels running along the surface of the pia mater. And some of these will be running within the subarachnoid space. So here it is. Here we have our spinal cord. This is our anterior view. So here's our anterior median fissure. It's kind of covered with some other tissues here. We see our pia mater that's been peeled back a little bit. Here we have our rootlets that are going to form our ventral root here. So here's some rootlets forming a ventral root. Here are our denticulate ligaments. Notice how they're spanning from the pia mater to the dura mater. And then we have got, here's some of the arachnoid mater that's been reflected back. And here we can see a blood vessel. It's traveling pretty much in the pia mater along the anterior median fissure. All right, so we've already talked a little bit about the composition of the spinal cord, we've got our white matter, our superficial white matter. It's mostly myelinated axons, hence it's white, because it's going to have that lipid appearance, that shiny lipid appearance, because myelin, remember, is basically just the bilayer of the myelinating cells. In this case, we're still going to be using oligodendrocytes. So we're going to have myelinated axons that are covered in this lipid-type phospholipid bilayer of cells. So most of the axons running in here are going to be myelinated. And so that's what gives it its white appearance. Then we've got our gray matter, and that's going to surround our central canal, which really you could sort of see sideways in section here. You can see half of it because they have either extruded this section up or cut the section away. And you can see that our central canal is this canal. It would be a hollow tube, well, hollow canal really, that travels the length of the spinal cord through the gray matter.